Mhm.
Okay. Well, good morning, everyone. And we bear warm greetings from sunny San
You're gonna
Diego.
have my
We're delighted to have you all here at this community conversation, which is titled Unheard Voices, what the 2024 Fatty Liver Survey tells us about the patient journey. Um, Next slide, please. By way of introduction, I am the Chief Medical Officer of the Fatty Liver Foundation. My name is Niraj Mistry. And let's go to the next slide. So just a brief background about the Fatty Liver Foundation. Our mission is to enhance the diagnosis, treatment, and support of Americans affected by the entire spectrum of steatotic liver disease, including MASLD, MASH, and METALD, through targeted awareness campaigns, comprehensive education, accessible screening programs, and robust patient advocacy. And we can't do this alone. And so essentially, we do this as a community of patients involved in various diseases. These are our disclosures and our disclaimer statements, and any information that's provided or shared is for education purposes, and clinical decisions should be done in conjunction and in partnership with your healthcare provider. Next slide, please. So today we're going to have myself and our founder and CEO, and who we like to affectionately call our patient zero when it comes to patient advocacy, Wayne Eskridge, who many of the community will probably know. Next slide. So the purpose of today's webinar is to share some of the key findings. This is the third year in which we've run the steatotic or fatty liver care survey in America. And this was to capture the real life experiences of adults living with steatotic liver disease. So we want to share many of the results from the survey, but the whole point of this community conversation is to talk about it. And how do we interpret this data? What is it telling us? How does it inform the decisions that we want to make? But I want to share a little anecdote about the evolution of this. And in the 90s, there was John Gray who wrote this book called Men Are From Mars and Women Are From Venus. And it really captured the psychological and perspective differences between men and women, often who seemed like ships passing through the night, or misunderstanding each other. And I think it's an interesting analogy to use between patients and providers. They come from different perspectives to the same problem, and very often they don't reach some point of convergence. And this was the impetus behind understanding what is the state of care when it comes to fatty liver disease in the United States. What are the patient perspectives, and how do we bring that forward in a more scientific way through a survey that can help inform clinical decision-making, provision of services, etc. And so that was why we actually created the care survey. And in its third year, we've seen a steady increase in the numbers, but we really need to expand it. And so we're happy to share some of this information today. The format is I will present some of the data. Wayne and I will have a brief to and fro with it, and then we'll open up after each data point to the participants on the call, and they can share their perspectives and their own experiences of it. Next slide, please. So that's the survey development and evolution that we talked about briefly. Next slide. And this is to understand the evolving social and medical experiences of individuals living with steatotic liver disease in the United States. And that will help inform the development of interventions, policies, and addressing population needs. Next slide, please. Okay. So this is when it started in 2022. And we looked at a lot of different questions, from clinical trial entry criteria to surveys that doctors were using to understand where their patients were, etc. And we consolidated all this information, consulted our very esteemed medical advisory board, and that sort of went into production of the survey. And now, particularly for 2024, with the change in nomenclature, we've expanded the scope of fatty liver disease to include metabolic dysfunction-associated steatotic liver disease. So definitely expanding the scope and trying to find the links across all these disease areas. Next slide, please. Okay, so here we go into our findings. We have 932 responses, so we are really, really chomping to get to 1,000 for the 2025 survey. So please look out for it when we send it out. Next slide. Okay, so looking at the demographics of the survey, you can see the age distribution, and between our 50 and 90 years old or 80 years old, that's where the peak of our respondents fell in. And there was also a higher number of female respondents, close to 70%. When it came to the gender distribution of it. And Wayne, this is quite interesting because as patient zero, you are a male and representing the minority of the respondents. And we do know from other medical studies that health-seeking behavior is higher in women than in men. A lot of men would not go to the dentist, for example, if it wasn't their wives pushing them to go to the dentist or scheduling those appointments. So that's predictable on what we would have seen from health-seeking behavior and paying attention, that diligence to it. What was interesting that we found when we compared our survey, the CARE survey in America, to the British Liver Society survey, the British Liver Foundation survey that they conducted, is that they had a higher number of men who responded to their survey compared to women. And so this was actually quite interesting with our cousins across the pond. Wayne, what do you make of this? And, how do you interpret this?
Hi, Niraj. Well, that is really an interesting comparison. You know, the description you gave of men not seeking care is something that we talk about a lot in the States. But the example in Britain is the exact opposite. And I think that this is a very graphic illustration of the differences that we deal with different kinds of cultures. I don't know why the men and women in the two countries are opposite like that, but it illustrates that culture has a huge amount of effect on how people engage with health care and services. And when we think about that as this a proposition in the States, we have all of these tremendous ethnic groups that we think about in the U.S. We're a polyglot of a country with every kind of society, and each of them have details, curiosities from our respects, but they have different approaches to how they engage with medicine or how they think about medicine or what they think medicine is. And I think that it's just a great illustration of how extreme those differences can be. And so as we try to gather data about how to best serve the different communities, you know, it really poses a challenge that I don't think anyone has figured out how to solve yet.
I think that's a really good point, and that's what makes the society beautiful, the diversity and the mixture of all the cultures. I will also say we will make these slides available as well as a recording of this community conversation. And I also want to add that This is just a very preliminary analysis that we've done. So a lot of this data is an aggregate of what the results of the survey will has been. But we will start disaggregating the data, and we've actually pulled together an analysis group of experts, both in epidemiology as well as disease and sociology, to help us understand this data, because we need to start disaggregating it to look at what the gender distribution is across the various cultures, etc. But I want to open it up to our participants on the call and see what your experiences were with health-seeking behavior across genders, and from your own personal experience. So we want to keep this very interactive. So please raise your hand or put your comment or question in the box, and we can sort of make this conversation much more interactive.
While you folks are putting in your thoughts or gathering your thoughts, something I'd like you to think about is the age distribution of this disease. We all have always thought of it as something that is old people, the cirrhosis, liver disease, that's an old person's problem. But you can see that we have a huge pulse at 50. And, in our society, that's what people think of the prime of life. I mean, that's when they're at the peak of their game. And yet we're seeing a lot of people with disease at that point. And I get a lot of calls, this disturbing number of calls from women that are in their 40s and still have kids at home. And they want to know, what's going to happen to my family if I die of liver disease. So this disease is moving steadily younger. And that's something that we're very concerned about.
And once again, looking at disaggregating the data on what sort of demographic is being affected at which age would also sort of breathe a lot of insight into how we track this disease and understand the patient experience. Tiffany, I just want to make sure that we are able to engage with our attendees. Oh, there we have someone who has raised a hand. Oh, we have a comment from Jen. Can we unmute Jen? Oh, Jen, can you accept to be unmuted?
Yeah. Can you hear me
There
now?
we go, Jen. Yeah,
Okay.
can hear
Okay,
you.
great. Yeah, I had to figure out my new tablet here too. Good morning, everybody. I'm Jen Jones. I'm the founder of Sober Livers, and our parent company is Fatty Liver Foundation. And so, a couple of things. I think, what Wayne said is true. Women are being really affected by this disease, and that may be as to why they're more apt to answer these questions on a survey. And however, I do think that it's important that we really try to make this more accessible to men. So I don't know if are we getting it? Are we getting the survey out to the same number of men as women? I guess that's one question. And how can we ensure that, the men understand the importance of this survey? I do think this is just my own personal opinion that in general, women are more apt to go to the doctor and to look into, what's going on, as opposed to just being like, oh, it's rub dirt on it, right? So that's kind of what I think. And from coming from the alcohol associated liver disease world, which we were a part of this survey this year for the first time, I will tell you that at our meetings, we do have men there, but it does weigh heavily on the women's side too. So we're going to try to do that as well. So, but yeah, this is a great look at showing, because same thing with alcohol-associated liver disease, the age group is just getting younger and younger and younger, and we need to determine why that is. And then how we can help them in this age group understand the importance of the liver. So that's what I'd like to say at this point.
Excellent, Jen. Wayne, did you have a comment?
Yes, the practice or the tendency of women over the years in the U.S. to be the health seekers has been well documented. But the other thing that we know is happening is that the rate of disease progression is advancing for women, both for obesity and for alcohol use. So that really is scary because women are determined to become as dysfunctional as men, in some ways, with some of the habits, it seems. So those are things that contribute to this imbalance. I see we have a question in the chat of, will these recordings be shared? And these will be put on our Zoom channel and distributed. So.
Absolutely. And I think another comment was made is that FLD is having its moment, which is great, and perhaps far more people will be diagnosed. But given the very scarce access to liver disease care, doesn't it seem unlikely that a radical rise in diagnosis will yield positive outcomes? And I think that is an interesting comment. And if one looks at sort of it from an behavioral economics point of view, with an increase in demand from patients, which we need to mobilize, sensitize, etc., we will then get the accompanying increase in services. And so it shifts the entire ecosystem as we sensitize people more to this condition. They get greater number of diagnoses and word spreads like that. And we've seen this across many other disease issues that we've dealt with. Should we go to the next data point, please? Okay, so this is also a distribution to now look at more of the nuanced cultural aspects. And I think, Wayne, do you want to comment on this?
Yes, we're trying to expand our reach into the various ethnic communities, and we focused very deliberately on the Hispanic group this year. We want to be able to do the same thing with the Black and Asian and American Indian populations, as well as the Pacific Islanders, because all of those have different genetic drivers that are important. Well, genetic and cultural, really. And we need to have more information about that, but it's really quite difficult. We're learning our way into how we might get acceptance in those communities, and it's a problem that everyone who's trying to deliver medical care across the board is facing. So we can expect to see in the future other efforts into how to approach different ethnic groups and to be satisfactory to their cultures and their understandings of how these things are used appropriately. So we don't necessarily know how to do it yet, but we're working hard to get there.
That's absolutely true. And one of the things we learned is one size doesn't fit all, right? And not for all cultures, not for all genders, etc. And I think the spike that we saw in the Latino community in this year's survey was because we offered paper surveys, and we also got help in Latino communities for people to interview to get the survey information. And that might be something that we need to also consider to get more men to respond to this on the methodology that we use to gather the survey data. You know, we'd be really open for our patient community and any participants who have ideas on how we expand the way in which we have people access the survey.
The hand up there.
I want to see if there's anyone else that has a comment to make. Can I just check with people who are attending the call that they are able to raise their hand if they want to make a comment or ask a question? Okay, there we go. Chris has a question or comment. Chris, go ahead.
I was just helping you, letting you know we can raise our hands.
Okay, excellent. Radhika, do you have a question or comment?
Yeah, I was just curious on what is driving the difference between the ethnicities. Are there like genetics, or is there like some other factor contributing to such widespread differences?
So that's a very, very interesting question. And I think we will be analyzing a lot of the research that was presented at the conference to try and find and understand those differences. But we do know, for example, at a very high level, that the type of NASH that manifests with Asian communities, for example, is lean NASH, which is a very different risk profile and a manifestation of disease compared to what white people or Caucasians might get. We also know that there are differences in the African American population on the manifestation of disease with the combination of comorbidities that are associated with MASLD and MASH. So I think we need to understand these differences far more. From that point of view, I want to turn to Wayne and Henry to see if they have anything further to add on this.
Yeah, one of the things that has plagued the country forever is the distrust that the African American community has for medicine. You know, there's a history of abuse that took place over the last couple of 100 years, and that lingers in the society. And so there's an element of distrust or suspicion that is just in there and very difficult to get past. We're trying to figure out how to deal with that. I think that it has improved from what it was 50 years ago for sure, but it's still, there's still a reluctance on the part of that community to trust medicine. And you know, the Latin Hispanic community has a I don't know, you'd call it what, a macho notion about medical care. They often tend not to seek care because that's less tough perhaps. But you know, there are elements of culture that we just simply don't know and don't understand that haven't been revealed to us that we need to be able to dig into.
Absolutely.
Henry, did you have something?
Henry? Oh, okay. So, and it feels like we're just scratching the surface with the survey, and we have to go so much deeper to understanding these nuances and differences across genders and culture, and then not just on the behavioral side, but then on the genetic predisposition, understanding physiology, etc. So it's an exciting time to understand, especially, you know, over the past few years, we've been talking about personalized medicine. So it all links to these factors. Tiffany, should we go to the next slide? There we go. So this was also very interesting, the diagnosis and staging. Um, so people were asked, what is your diagnosis? And so they listed their diagnosis. And what we did do in this year's survey is we expanded the scale, the spectrum of diagnoses based on the change in nomenclature and moving from NASH to MASH and NAFL to MASLD. In addition to the diagnosis, we also asked at what stage were you diagnosed? And so you can see about a fifth of the people didn't know what stage they were diagnosed at, but the majority was MASLD, and then you had the various stages that people were diagnosed at. Wayne, do you want to make a first comment about this one?
Yeah, you can look at the circle on the right and you can clearly see the tragedy in the way that we manage the disease. The stage 4 is 18%. That's a gigantic number. And those are people with stage 4 cirrhosis. It's just unconscionable to me that we allow people to get to that level before they're diagnosed. We're doing better, I have to say. Over the years, we've been complaining about this trend, this fact that medicine is not intercepting us as patients early on when it's easier to cope with these diseases. But 18% is totally unacceptable from our perspective.
And this is part of the education awareness campaigns and screening campaigns that is sort of our lifeblood at the Fatty Liver Foundation, where we're saying it's not so much the patient meeting the medical system, but it's about the medical system meeting the patient. And if we can have medical services, education, awareness, screening at a community level, we can get to people much earlier. And so we almost want to sort of go back to MASLD and stage 1 when it comes to diagnosis, and reduce the stage 4 and the stage 3. So definitely more proactive campaigns rather than a health service being reactive to people coming there. I wanted to see if there were any participants that had comments on this. This is quite interesting on the stage in which people were at which people were diagnosed and the distribution of disease. Amanda had her hand up. Amanda, go ahead. You can unmute.
Sorry, I did that by accident.
Oh, okay. Okay.
Well, jump in anyway. That's a good idea. One of the things you might, if you look at the graph on the left, you'll notice that the MASH is quite high, 35%, and that's high. Well, that's really because we are reaching out to our most active patient groups. These are the people that are more concerned. That's a higher number than is in the population as a whole, but that just gives you a little sense as to how the makeup of the patient population that is engaged in trying to learn about this disease, because nobody comes to our websites or does our surveys that doesn't care about liver disease. So that just gives you a sense of the mix of the kinds of people that are participating in this advanced effort to understand the disease.
And I think the other thing that is skewed on the diagnosis is the fact that we introduced MET ALD and ALD and the other forms of MASLD into the survey this year. So the networks through which we distributed the survey were leaning more towards MASLD and MASH related disease than alcohol-associated liver disease. So I think that's something we're definitely going to be building upon to see how we can get it more representative on the prevalence of disease in the community. We have a raised hand from Pete Solano.
There, I am unmuted. Can you hear me?
Yeah, we can hear you.
Thanks for calling on me. I wonder if it's because of the dearth of imaging in primary care. You know what's a disease state that's beautifully diagnosed in America today? It's heart failure, really high acuity cardiovascular disease, because in so many advanced primary care locations, they do an echocardiogram. But until and if we have Sonic Insights and eScopics and FibroScan in primary care, will the diagnostic rate be spiked? It's not like it's going to happen in hepatologist's office. There are far too few.
Oh, I think you're absolutely right. One of our challenges is how do we get the technology distributed and used by primary care, because that's where we need to have it. The technology does exist, and the standard guidance says that it should be used by primary care, but they really haven't adopted it. So that's one of the challenges of the next few years, is to find ways to get primary care mobilized.
There's an economic incentive for them, right? It's called risk-adjusted factor. So if they're at-risk primary care, right, ACOs like Oak Street Health, they get more money in the subsequent year if they discern disease. So they actually get both incremental revenue, and to the extent that they move that patient into an efficacious care pathway, lower costs. So it would seem right in front of us. They did it for cardiovascular. They must be ready to turn to some other expensive prevalent disease state.
It seems like that should work. We haven't seen a big uptake of it yet, but conceptually it's the right kind of motivation. So we're optimistic we'll see more, but it's a slow process.
Yeah, and all these scanning players are tiny, right? Whereas for cardiovascular disease, Philips, GE, et al. Were oh so happy to sell their ultrasounds into primary care. So there might be a relative dearth of strong scanning companies too. Thanks for letting me comment.
Great. Jen, did you have a comment?
Yeah, and thank you for that last comment. I really appreciate it, because I do agree, and I think that that's a messaging issue, because you're saying that this actually yields some good things for the PCPs, and I don't know if they're getting that message. I think it's really important and strong that we really advocate within the PCP environment, because, when I look at this as a person with alcohol-associated liver disease, cirrhosis recompensated, I found out I had fatty liver at one point back in 2013, but it was told, they were too worried about, I had some mental health issues at the time from severe intimate partner violence. It's like, oh, this is going on, but don't worry about this right now, right? And the other thing with alcohol is we don't get these stages. We don't get like stage 1 compensated cirrhosis, or I guess it would be stage 1 alcohol-associated liver disease. Steatotic liver disease would be our stage 1. That's what I would probably have been at that point in time. But it seems like that we don't get diagnosed at very much like the MASH patients until they're stage 4. But we don't go through stages per se. It's just you have a steatotic liver disease, compensated and decompensated. And I really hope that we can start aligning more with the mast cell side of things so that people can really treat their disease early on and don't develop into cirrhosis. So I hope like next year we'll have a different chart on here, which will have mast cell ALD/ALD, met ALD, you know, and we'll start being able to really look at these different categories as they evolve.
But yeah, that would be something that needs to happen because it's really not fair to have to ignore the early stage liver disease just because it's causes by alcohol.
Exactly.
And I think with the shift in nomenclature, we're going to start looking at it in a much more integrated way, which includes staging. And there's often dual risk factors on the alcohol side as well as the metabolic side. And then I do want to respond to also Pete's comment where through the Sun1 study that the Fatty Liver Foundation did, they literally went into practices, set up screening in the rooms with imaging devices, and conducted screening for high-risk patients that were identified by the primary care providers. So it is very, very doable, and we have models of that. But in addition to that, I think non-invasive tests and using a simple thing like FIB4s are an important screening tool that we can offer and raise awareness among primary care providers. And one interesting point that came up from some of the providers we spoke to was that, well, they didn't want to screen for this because there was nothing they could do about it. On the lifestyle interventions, there's a lot that they could do, but they couldn't offer their patients treatment. And so I think we at a point, excitedly so, that we have treatment available. And so there's an incentive to screen, diagnose, and then put patient on some sort of treatment. There's a couple of questions in the chat box. Christina asked, how were the subjects staged? Wayne, do you want to respond to that?
It's a variety. We didn't have any control over how they got there, but most were done with FibroScan. Some had MREs, some had biopsy, but the majority were FibroScan.
Absolutely. And then we talked about why we think ALD is so low considering its presence in our society. And I think part of that is tapping into the networks that we distribute the survey to. That would be more representative of the distribution in society. Participants were not paid for the survey. We have explored incentives for people taking the survey, and it becomes really, really tricky on the authenticity and with which they respond to the survey. So we wanted to stay away from those incentives. Chris has a question. Would be interesting to know what percentage of patients are confused about what to call their disease. I have to say the confusion has not only been on the patient side, but we've also had staging challenges on the provider side when it came to disease. Wayne, do you want to take the question from Chris?
Sure. Probably the clearest number we have is the number on the right of that circle. It says they don't know. I think the ones who listed them as specifics probably were accurate. They probably had that information, but 18% who had no idea is a pretty big number.
And that's on the staging side. But I think Chris's question also refers to on the diagnosis side. So when we have this really big umbrella and people could fall into various categories, especially when there may be alcohol use, but also other comorbidities, the classification of disease then becomes a bit of a challenge. And I think now that we have these categories like met ALD or ALD, I think we'll be able to classify better, but this is once again with education of PCPs that we're dealing with as well. Should we go to the next slide? Okay. And I think, yesterday at the liver meeting, there were excellent panels on lifestyle changes and the patient journey. So this slide data point is looking at the diagnosis and staging. What happened when you were first diagnosed by a medical provider? And I think we've heard this over and over again. They were told to eat healthy, lose weight, and then referral was also very, very important. There was more testing that was done to confirm diagnosis and staging. And then this is a worrying thing when they were told there's nothing to worry about. Wayne, initial reactions to this?
Yeah, I'm always offended by that. Nothing to worry about. One of my favorite studies showed that F2 and F3 are more dangerous than smoking and diabetes. And we pay so much attention to those two things and we ignore the F2, F3 so commonly. So I think there's a disconnect on the part of medicine as to just how dangerous it is to have liver disease.
And there was a paper that was presented here at the conference, which on a study done in Germany, which showed a higher all-cause mortality in people with F2, and so that's quite telling, especially when we're looking at F2 and F3 as a key indication for drug intervention. So I think we have a huge opportunity there at the moment. I just want to see if there's any other participants who have anything to share about their journeys on what they were told needs to happen once they got a diagnosis. Chris Burns.
Yeah, hi. Thanks for the talk. 4 years prior to being told that I was stage 4 end stage and I had just days to live, I was told I had minor cirrhosis. There was nothing to worry about, and I wasn't sent anywhere. And it was, not to say the least, infuriating 4 years later when I was diagnosed and had to change everything in my life. But yeah, I think that is a huge question why any doctor would say that. And this was a primary care physician who, got me to the test, got the results, and then told me that. And it was like, oh, okay. And as a layperson, I didn't know what cirrhosis really was. So I didn't do much research, and there was no follow-up on it whatsoever. And this was in a major metropolitan area of San Francisco, where you would think that they would, Kaiser Permanente, follow up, send me to the specialists, and, do something to do that. So that's really concerning to me that other people were in my situation.
It's mind-boggling because we often talk about this as a silent disease, right? And so when there was like a 4-year lag time without silence, because there was an initial diagnosis or pickup of something, and then nothing manifesting on that. So I do hope that the landscape is changing now with broader awareness of things. Jen, do you have a new hand up?
Sorry about that. No. I just didn't lower my hand. I'm not
Okay.
following my Zoom instructions very well.
Okay, so this slide has been very informative for us, and I think this is an area that is informing our actions as a patient advocacy organization and the broader patient advocacy community on what are those steps that we need to take in order to ensure that we're supporting patients at the time of diagnosis, whether it's referral, the engagement of multidisciplinary teams, putting them on medication. And I think we have much more options now. So hopefully that would change things. And next slide, please, Tiffany. Okay, so here's the medical management, and who is your care team made up of? And so once again, PCPs are your first point of call, and then referral and the makeup of the multi-disciplinary team. And we've seen anecdotally from conversations with many of patients is that they had to do everything from configure a team themselves to being in a practice with a primary care provider that referred them to various services, to being at centers where they had access to a multidisciplinary team. Wayne, I want to see what your experiences were like, and then also open it to the group to share some of their experiences on the type of management they received.
My journey was a few years ago when it started, and at that time, I basically had to do everything. I even had to insist that I get referred to a hepatologist. I mean, it wasn't really offered to me, and that was critical to my care. And a story that I chuckle at this point is that while I was at that hospital, they referred me to their hospital dietitian. And the dietitian gave me advice that was totally opposite of everything that the hepatologist had told me. So I was, I had two medical professionals telling me diametrically opposite things, but I did follow my hepatologist. I had to contact the various specialties or services myself. There was no instructions, no guidance, no help in deciding what kind of services I needed, really. But that has been changing, and we see a lot more care teams that are formally organized today than we did then. So I feel good about the direction it's going, but most of them still exist essentially in the major metropolitan areas. And so a lot of people don't have access to functional care teams. And it's really valuable to have a care team because there are a lot of pieces and parts to these diseases that need to be thought about. Well, I think it's fragmented. I think if you're in a decent sized community, if you happen to be Medicare, you probably got a decent care team. If you're private insurance outside of a metropolitan area, you probably have less support that way. I imagine some of the patients that we have on here have some thoughts about that if they'd like to comment about it.
Chris, go ahead.
Yeah, hey. So Wayne and I are from the same town in Boise, Idaho, and Niraj, I spoke to you about this yesterday, but I find it amazing that hospitals don't have this multidisciplinary team outside of transplant centers. I was lucky enough in our small town to have that program available to me with all of these people and a head specialist that navigated my entire care over the course of my pre-transplant journey. And just a month before I got transplanted, they shut the program down because it wasn't bringing in the big ticket, big dollar surgeries and it's unbelievable. And my question, I guess, would be, is it because it's not financially, there's no financial incentive in terms of making people healthier and curing them? Or why did this department get shut down, and why isn't this more popular in places where it's not even a transplant center, but just a hospital?
Can I take a whack at that one, Niraj and Wayne? Chris, it's a great question. Pete Solano here. You know, the incentives aren't aligned, right? In the fee-for-service realm, which sounds like where you were, right, versus value-based care, if they don't have hepatologists, notwithstanding functional people surrounding that hepatologist, they have no incentive to see you. They have no ability and certainly no incentive. But you know what could change is the rise of value-based care in America. So take a look at a similar clinical entity to liver, kidney. It's radically at risk now. CMS, right, Medicare and Medicaid in Baltimore has decided a while ago that kidney care wasn't so great. No disrespect to that duopoly Fresenius and DaVita. So they put forth a program where nephrologists, that's a kidney doc, right? They have every incentive to get you in and address more than just your kidney disease. And that led to the rise of some new players, disruptors. I'll name three: Somatis, Strive, and Monogram. So perhaps this will be addressed at some point by CMS. They have now 10, 12 specialty value-based care programs. At some point, if they circle liver, things could get better. Does that make sense?
Yes, thank you very much. I appreciate it.
So, I mean, the way healthcare is modeled, you know, competition is gonna bring a better product or service to the market. And so I do think that when there's more players in the field demonstrating different models of value-based care, we're going to get a better service, hopefully, then for the patients. I also think we need to look at, and we'll, at the Fatty Liver Foundation, we'll look at the literature on it. We did look at the costs of transplant, right, which are much, much higher compared to earlier interventions. And that's the compelling case to make, that if we get to patients earlier with a multidisciplinary team that's going to halt, reverse, or prevent the progression of disease, our future cost savings are going to be much, much more. We're not going to be able to cope with the level of transplants that are going to be required if we don't get to the disease earlier and you know, implement these interventions earlier. So I think that's the other big compelling case to make. And I can't help but think that the health insurance companies are looking at that at this point, especially now that we have drug therapies to look at. I want to be cognizant of time as well. Should we go to the next slide? Okay, so this has been interesting. In order to move the field forward, we have to have more trials. And in order to do more trials, we need more patients involved in that. And Wayne, from your experiences, what have been some of the incentives or barriers? And I understand that you also looked at some of the trials or were involved in one. So tell us about those sorts of experiences.
Well, I've participated in one trial. I've attempted to participate in a couple of others and wasn't qualified. But I think one of the biggest problems we have with that is that most physicians don't encourage patients to join trials. You know, when they're too busy putting them through the process, and so many patients really never get asked the question of would they have an interest in being in a trial. And then even if they do, we wonder how effective the explanations of the value of trials is. You know, it is critical to the medications that we all want to have. So if we can somehow change that tiny, tiny number to a more robust participation, the whole field will be further ahead. For those that are here that haven't perhaps been in a trial, we all worry about, being a placebo, for example. One of the nice things about the rules is that if you're in a trial, you do get standard of care, even if you're a placebo. And standard of care now, when we have Resdifra, will be that that's the that's the basic case. So most of the future trials will have as a minimum that a patient gets the Resdifra and another drug or a combination drug. So if you have any reluctance about that, that's one thing. But the other part about being in a trial is you get the very best care that is possible for medicine to give you, because they are the last thing that they want to have happen if you're in a trial is that you have some kind of a problem. So being in a trial carries with it the benefit, even if you were a placebo patient, of having the very best care that they know how to do. So anyone who's listening or thinks about that, volunteering for a trial is a really good thing.
And I should add that with our online patient community platform, the Wellness League, we have more information about trials, and if people are interested, how to go about it. And we can certainly be responsive on it to let people know what the opportunities might be to be engaging in trials. Pete, is that a new hand up? Okay.
Sorry, Niraj, I just lowered it. My bad.
Okay, no worries, no worries. I really appreciated your comments. Wayne, what recommendations would we make for patients if they are interested in trials? I mean, they can certainly join the Wellness League, and there's also a roster of trials that we can share with the patient community.
There are a variety of tools out there, people that are proposing trials. We can help you connect to them or just do a search for them. There's also clinicaltrials.gov, which you can go to, but speak to your physician. Your physician, may well know what might be available in your area. And, Google clinical trials for you in your area, and that may give you, the people that are presently doing them. And so it takes a little digging sometimes to figure out what's there, but there are a variety of ways that you can come across that information. If you know about a trial that you'd like to participate in, it's easily searchable by just going to Google, and you'll be able to get to the company that's doing it.
So that's great. And then we will also try to make that information accessible through the Wellness League. I want to just respond to a question that Callie raised in the chat box, which relates to the slide before, which is there any additional information that says who is leading their care team rather than contributing to it, assuming the PCP? And this is something that from a patient point of view, we've been sort of toying with and looking at different models, because when you have a multidisciplinary team, you kind of need the quarterback to call the play and coordinate that care for the patient. In many settings, it is the primary care provider that is doing that. There are huge concerns around the amount of time they have, the amount of administration that's required, whether they have practice managers or case managers for patients. There may be an opportunity to look at the hepatologist as being central to that multidisciplinary team, especially if they are going to be the ones prescribing medication. And then we also exploring something called patient navigators. And this is where it's like a case manager, often at a community level. It could be among peers, but we're looking at that virtually, as well as from other examples like hepatitis and HIV. We've seen on the ground in-person engagement with patient navigators. And so we are sort of exploring these models to think through what is that type of service that would best put our patient community in a position where they could access most amount of care in an optimized model, and ensuring that it's comprehensive. So definitely a space for us to look at in future. Next slide, please. Next slide. And so definitely we are expanding our networks. We want to get our numbers up. We want the survey to be more representative of the general population. We also, have it in Spanish and in English, but we're looking at Mandarin and Portuguese for the next iterations of the survey. The more we can engage our patient networks, our provider networks as well, the more patients that we can actually get to respond to the survey, and that's going to give us more data. We have established, like I said, a data analysis group of experts. And so we want to now, especially in the era of big data analytics, get more nuanced and detailed data with the correlations across various fields that we're looking at in the survey. So exciting time, and we're getting a bit impatient with the amount of data that we get, so we can use it to effect change. But it is a process that we're going through. Next slide, please. So that's the end of the community conversation. But Wayne, I want to open it to you to give your closing comments on the care survey and what we found, and just, to wrap things up.
Thanks, Niraj. Appreciate those of you who joined us and those that'll watch it on our YouTube channel in the future. This is an important work because what we are tracking is the changes over time of how medicine treats patients. We can see from one year to the next whether or not doctors are providing more information to patients, for example, how the referral patterns change, at what point are people diagnosed. Those are the kinds of data points that we can use then when we go to lawmakers or to pharmaceutical companies or to educators to say, this is what is happening in our society. And, if we don't have data, it's just opinion. So it's important to us to be able to get your feedback, your experiences. We need to have an increasing number of respondents so that when we speak on your behalf, it carries weight, and the people that design systems and decide who to pay and how this is all going to operate will do so with knowledge about what's truly happening to you as patients. And so we appreciate your support, encourage you to always join with us in the coming surveys through the years, and to encourage friends and other people that that are in the community to join with us in this information project. So thanks for attending.
Excellent. Perfectly said. Thank you all so much. And we look forward to staying in touch. Take care.